Thank you very much. So in the interest of time, I only have 25 minutes. I'm going to focus on GABA and talk about GABA in psychiatric and neurological disorders. Again, I'll use some of these features, so please log in now. And actually, the next question is going to be a poll that I'm going to see if it works. So the question is, who is currently working with clinical populations, who's interested in working with clinical populations, and who is focused on basic science? Do you know if it will come up? Right, maybe show of hands. Who is interested in working with clinical populations, or currently working with clinical populations? Who is not currently but is interested? Okay, pretty good. All right, we can go back to the PowerPoint now. All right, so we got a nice range of people. So the goals of my talk is for you to understand in which disorders GABA is thought to be altered and how these alterations might occur, to understand how spectroscopy can play an important role in understanding neurological and psychiatric disorders, and to understand how MRS can and cannot be used for diagnosis and treatment development. So I'll first talk a little bit about GABA, refer back to Professor Ray's talk in terms of where things might be going wrong. I'll then talk about considerations for designing your clinical studies rather than just jumping out and talking about 25 different disorders. But I'll use some disorders where GABA is altered to point out these considerations, and I'll talk about age and development as well. I'll then spend some time talking about pharmacology and some of the limitations of working with these populations. So we know that GABAergic transmission plays a key role in healthy cortical functions, healthy behavior, and cognition. And so when GABA isn't functioning properly, that can really lead to large repercussions and therefore to psychiatric and neurological disorders. It is widely distributed in the brain, has important roles in inhibitory-excitatory balance, synchronization of cortical activity, as well as plasticity. And there's a large variety of GABAergic drugs on the market that we know work in a variety of different disorders. And I put GABA here in quotation marks because, as Professor Ray mentioned, these are wide-ranging drugs. They don't point to a specific GABAergic function, and some don't even function on GABA at all. They just kind of secondarily affect the GABA system, and so it's important to keep that in mind. But these drugs do seem to work, and sometimes people are less interested in the actual mechanisms of the drugs, in the fact that they do something to the patient that makes their lives better, which is ultimately what we were trying to do. In addition, repetitive TMS is a technique that's being increasingly used to target specific aspects of disorders, particularly depression currently, and I think that has some effects on the GABAergic system as well. The thing I would like to point out right now is that MRS of GABA is currently not being used for diagnoses. All the studies I'm talking about are research studies. It's currently not being used in the clinic. So a couple of years ago, Richard and I reviewed the GABA MRS literature, including focusing on kind of clinical applications. And we found then that the majority of clinical studies looking at GABA at that point were focused on depression and related disorders, as well as schizophrenia and epilepsy. And then quite recently, Schur and colleagues did a fantastic review where they also did a meta-analysis of the results found in papers, but they really focus on a number of different disorders, including major depressive disorder, schizophrenia, and autism, as well as some other ones. Another area of interest that has been studied widely is pain disorders as well. And so there's a wide variety of research focusing on these different disorders, and if you want to know more about specific disorders or what disorders have been studied, I would point you to these reviews. But I first really want to talk about where things might be going wrong in the GABA system. And as Professor Ray said, the GABA system is a very complex system. What we're measuring is all the GABA within this huge predefined region of cortex, and so we can't differentiate where our GABA deficit is coming from. This could be, for instance, due to macroscopic drivers, such as differences in cell density or differences in synapse numbers, but it could, for instance, be in terms of the production, breakdown, and receptor function of GABA. So it could be, for instance, in glutamic acid decarboxylase, or GAD, which has two predominant isoforms, GAD65 and GAD67, that affect the production of GABA, and so an issue there might lead to differences in GABA. However, it could also be in the transport of GABA. GAP might be affected, or GABA aminotransaminase might be affected. That leads to differences in the breakdown, the transport and the breakdown of GABA. And finally, GABA might be, or the GABAergic system might be affected in terms of GABA receptor function, as Professor Ray nicely outlined. And there, the relationship to that and the overall GABA as a neurotransmitter that we measure is perhaps less clear. There probably is a relationship, but it's quite complex and not as direct. And so the issues could be in terms of GABA production, could be in terms of GABA transport, which is more kind of presynaptic, astrocytic, or GABA receptor function, which is more in the synapse and postsynaptic. And it is possible that there's disorders where you have a collection of patients which have different fundamental underpinnings. There could be people with differences in GABA receptors or differences in GABA production that show very similar phenotypes. And this could happen, for instance, in disorders like autism or schizophrenia, where there's a wide range and a lot of heterogeneity between disorders. Having said that, with MRS, we do measure differences in the amount of GABA that we have, which does point to differences in neurotransmitter, or at least GABAergic availability, which might have large repercussions on cortical functioning and behavior. And so it does allow us to tell us something about the GABAergic system and potentially look at diagnosis or treatment. So here's a poll. What do you expect to see in a patient who has antibodies against glutamic acid decarboxylase? See if this works. And we've heard this mentioned a couple of times now. All right. Does GABA go up? Does GABA go down? Or do you see no difference? I've got 1 vote so far. 2 votes. All right, 5 votes. Okay, we can go back to the PowerPoint now. Some adjustments, but most people talk about it that way. So there's actually a disorder called stiff person syndrome. And stiff person syndrome is not very common, but it's characterized by muscle spasms, muscle rigidity, as well as epileptic seizures. And it can mostly be diagnosed by titrating for glutamic acid antibodies. And about 65 to 80% of patients have antibodies against glutamic acid 65, which means that that enzyme isn't working properly and is therefore not producing GABA properly. And so in this study, they used 2DJ spectroscopy in a small group of patients and controls, and they measured GABA in both cortical regions as well as subcortical regions. And what they found was that the GABA levels were substantially reduced in the patients to about 40–50% in these patients, particularly in the cortical regions in the parietal lobe, but not in the subcortical regions or the frontal lobe. And so here what we're seeing is that we know that in these patients GAS65 is affected, therefore affecting production of GABA, and we can measure that difference in production of GABA using magnetic resonance spectroscopy. So I want to use a number of disorders to talk about considerations for designing studies and what you might be able to learn from working with patient populations. So I first want to talk about the specificity of measurements, talk about neurodevelopmental disorders. I then want to talk about the heterogeneity of disorders, as well as establishing the right outcome measures in disorders, and do that with respect to depression. I want to talk about function and behavior with respect to borderline personality disorder, and establishing a clinical trajectory with respect to schizophrenia. And then I'll talk about development and pharmacology a little bit. So my own work focuses on neurodevelopmental disorders, so I'll talk about that first. So I work with children with autism spectrum disorder, children with Tourette syndrome, as well as children with attention deficit hyperactivity disorder. And obviously these are very distinct disorders with their own etiologies, but there are some behavioral commonalities between the disorders. Now, what is common between these disorders is that there's quite a wide body of evidence suggesting that GABA is altered in these disorders. And so we scan children and we put them in the scanner, we measure the GABA levels. And so in autism, we found significantly reduced GABA levels in the sensory motor cortex of these children. We were absolutely not the first to find this, we were not the last to find this. Seems to be quite a consistent result, where you see reduced GABA levels in the motor cortex or sensory motor cortex of children with autism. What is also quite consistent and very interesting is that visual GABA levels do not appear to be affected in autism, and I think that is something that I'm happy to discuss afterwards why this might be. But that is also a consistent finding, so there does seem to be some regional specificity to these findings. However, we also see reduced GABA levels in children with Tourette syndrome, and in a previous study we also see reduced GABA levels in children with ADHD. And so reduced GABA levels per se in children isn't an index or provides diagnostic information about the disorder. We can't just put an 8-year-old child in the scanner, see reduced GABA levels and say, well, this child has autism. It's also not really relevant because autism is diagnosed at 2 or something like that. And so it's not really relevant. What becomes more important is that we learn something about the behavior outcomes. And so we don't see any specificity in these disorders. We know these disorders are heterogeneous, so this kind of average GABA levels, how meaningful is it? What we really need to look at is, are there relationships with any clinical features that are informative? Now, in our results, in all these studies, we do actually find very specific behavioral deficits relevant and specific to the disorders that GABA correlates with, but I actually want to talk about that with respect to depression. So GABA in depression has been a long interest, and in this study, GABA was measured in the anterior cingulate cortex of youth with depression. But in this case, they separated out youth with depression with anhedonia and without anhedonia. And anhedonia refers to an inability to feel pleasure, which is one of the comorbidities of depression. And so they did this in quite a large subject number, so 44 people with depression and 36 controls. And what they found was that ACC GABA levels were significantly lower in depressed youth with anhedonia, but they weren't significantly reduced in those without anhedonia. And so here you have a disorder where you have a subgroup that is affected in terms of GABA levels and a subgroup that isn't. And in disorders that are heterogeneous, you need to be very careful that you don't pull all these data together necessarily, because you might not see a difference, because it's really different by subtypes that are slightly different chemical subtypes or different chemical mechanisms underlying these. In addition, they also found an important correlation. So here on the x-axis you see GABA concentration, on the y-axis you see anhedonia score. And it was those participants with higher GABA levels who had less anhedonia, so were less affected in terms of the disorder. Whereas those participants with lower GABA were more affected in terms of the disorder. And so here you really start stratifying a disorder in terms of GABA levels, where GABA levels point to a very specific processing deficit within this disorder. Again, choosing your symptoms and outcome measures here is very important, because if you look at maybe a generalized depression metric, you might not see these differences. But with anhedonia specifically, knowing that that behavior is also related to ACC processing, you do see these differences. And so choosing what symptom you're interested in might provide you more power and more interest for looking at these disorders. I also want to talk about the study with borderline personality disorder, which is predominantly identified by impulsive behavior as well as sensation seeking. And in this study, they measured GABA levels in all female cohorts of patients with borderline personality disorder, or BPD, as well as a matched healthy control participant group. And they used suppressed measurements. So they looked at, they actually suppressed the macromolecules to get a more pure GABA measurement. And they found, they also did an fMRI task where they look at interference inhibition, which is a measure of inhibition and impulsivity, but more approached cognitively. So they found lower ACC caudate functional connectivity, both in the ACC and in the caudate, in these BPD patients. Now, in addition, they found that in these patients only, anterior cingulate cortex GABA levels correlated significantly with the ACC and caudate bold activation, as well as the functional connectivity between them. And so what they have here, they started linking the neurochemical level with the functional level. It becomes more interesting when they start looking at clinical measures. So they found that both GABA and ACC caudate connectivity, as well as the caudate activity as well, significantly correlated to this a clinical measure of sensation seeking. And so then what you can then do is do a mediation analysis, because they found that both GABA and bold activation related to this measure of sensation seeking, but they're also related to one another. And so we found that the relationship between GABA and this behavioral measure of impulsivity was significantly mediated by the bold activation. And so what you can start doing here is you start getting much more of a mechanistic idea of the system that you're working with, because you don't only have the kind of cortical functional connectivity measure, you actually have to what extent does the neurochemistry that underlies this relate to both the connectivity as well as the behavioral outcomes. And so you get a much more of a full picture of a mechanism in a disease, and maybe more points in which you can start interfering, providing treatment, or at least tracking this disease itself. Schizophrenia is one of the most widely studied disorders, and the GABA glutamate hypothesis of schizophrenia is very prevalent. There is this idea that there is glutamate-excited toxicity in the brains of people with schizophrenia that leads to neuronal damage. Also, too much glutamate leads to inefficient GABAergic function in these patients, and there's also been an implication of glutamic acid decarboxylase, the 67 isoform in schizophrenia. So in this study run by Laura and colleagues is very important, because it was one of the largest studies done in schizophrenia, and I'll get back to sample sizes in the limitation section, where they measured GABA in the anterior cingulate cortex in a group with an older group with schizophrenia and a younger group with schizophrenia. And they separated the analysis. And they found that GABA levels were significantly reduced in the older group with schizophrenia, but not in the younger group with schizophrenia. In addition, they did a linear regression where they found that there's a increased decline in GABA in patients with schizophrenia compared to typically developing controls, where GABA levels decrease slower with age. And so what you start looking at here is a trajectory of a disorder, where early in the disorder you might not see differences because the disease hasn't progressed yet, but later in the disorder you might. And so understanding the clinical trajectory of a disorder is incredibly important, because this really leads to understanding outcome measures, the progression of a disorder, when you can intervene, etc. And so this study is important for a few number of reasons. One is they use a very large cohort of 145 patients, which is very important. Secondly, they use this macromolecular megapress sequence, but they replicated their results of lower anterior singular cortex GABA levels in older patients in a study from 2012 where they measured GABA+. And so they used two different techniques here, but they found a consistent result in terms of reduced GABA levels, and I think that is also very important. But the most important difference here is that they found a difference in the age trajectory between patients. Now, what is more important is, can we actually identify a disorder before onset of kind of active symptoms? And so in this study, they measured cortical GABA levels in subjects at ultra-high risk for psychosis that they measured using a community assessment tool for at risk for psychosis. And in 20 patients at ultra-high risk, as well as 20 healthy controls. And they measured GABA in a frontal voxel because that's been associated with psychosis before. Now, they didn't find any significant differences in GABA levels. This is consistent with the previous study by Roland and colleagues, where they, in the younger cohort with schizophrenia, they also didn't find any significant differences. However, they did find a difference in terms of the relationship to this measure of at risk for psychosis, which is separated in positive symptoms and negative symptoms, where more negative symptoms is more likely to end up in psychosis. And they found that those participants with higher GABA levels had fewer negative symptoms, so fewer prodromal symptoms for psychosis, where those participants with lower GABA levels had higher, were more at risk for psychosis. And so here you can start looking at the early trajectory of a disorder, which is incredibly important, because early identification of a disorder leads to early intervention of a disorder, and pretty much in all disorders leads to better outcome measures. And so being able to identify a disorder very early in its development, or even before onset, when onset might occur, is very important for targeting treatment and targeting behavior. GABA and glutamate and other MRS measures have been widely described in schizophrenia. So obviously, I don't know, I could spend 2-3 hours just talking on schizophrenia alone. But I would say that there's two excellent reviews out there, one by Gerard Dwyer and colleagues, and one by Jeroen de Jonge and colleagues. And if you're interested, I would look these up further. So aging and development is important, and Dr. Harris talked about aging and development somewhat. So the results on aging and development are very wide-ranging, they're not consistent, and studies use different techniques, different sample sizes, etc. But they also use different cohorts. And so together with Eric Porges and Greg Jensen, we recently did a meta-analysis of the data on the age trajectory in terms of GABA levels, where we looked at all the study that had a wide enough age range where the individual data points were plotted. We extracted these data, and then we normalized them first within group and then across all the groups, and then looked at the age trajectory. And we used a number of different models to see what best fits this age trajectory, but we found that the log normal fit fits this best. And so what we see when we combine all these studies, and therefore massively increase our power in terms of the data that we have access to, is that GABA levels increase very significantly, very quickly early in development, but then taper off around adolescence and early adulthood, and then have a slow decrease. Now, it should be taken into account, as Dr. Harris said, that there is a tissue component to this effect, and some of these data were tissue corrected and some were not. So this is definitely a limitation. But this does seem to be the trajectory that is most consistent, and is consistent with other age trajectories in terms of cognitive function. Now, what I should mention is there's a huge gap before 6 years old. Scanning children before 6 years old is difficult, but we're trying to do this. And I think that is important to see what happens very early in development, because we know that GABA plays a particularly important role in early development. Now, in the last bit of my talk, the last couple of minutes, I want to talk about pharmacology, because obviously pharmacology is very important in treating disorders. And so the first study I want to talk about is gabapentin. So gabapentin mimics the action of GABA, but it doesn't actually bind to GABA receptors, it binds to calcium channels, and therefore mimics that action, and is most often used in the treatment of epilepsy, anxiety disorders, as well as migraine. Now, in this study, which is one of the earliest studies using editing to look at GABA in patient groups, they gave gabapentin at 2 different doses to groups of patients with epilepsy, and they compared their GABA levels to a group with matched epilepsy drugs that weren't particularly GABA focused, such as valproate. And they found that the GABA levels in patients who get gabapentin were substantially higher than in those who are not on GABAergic drugs. In addition, the number of seizures decreased substantially in the patients, particularly on the high dose. And so here, you can start tracking the response to a treatment on GABA by measuring GABA using magnetic resonance spectroscopy to see whether GABA levels themselves change within the brain. However, this doesn't always work. So in another study where they looked at the GABA response to acute benzodiazepine administration in panic disorder, they gave patients with panic disorder as well as comparison subjects benzodiazepines. So in this case it was clonazepam. And benzodiazepines increase the efficacy of GABA receptors, but there's also this idea that it actually affects the glutamic acid decarboxylase, so affects the production of GABA. And so what they did here is they gave these patients benzodiazepines and measured GABA levels acutely after giving them these drugs. And they found in the comparison subjects that GABA levels on average, can't see it. So in the comparison subjects, GABA levels on average went down. And GABA levels also at baseline were actually higher in the controls than in the patients with panic disorder. However, in the patients with panic disorder, benzodiazepines didn't actually affect the GABA levels. It did nothing. And I think this is very important because it shows that when you have an abnormal GABAergic system, drugs that affect GABA might respond abnormally compared to patients. You can't always expect that your system is working the same in a population where that system is altered. And so in this case, the patients didn't respond. And non-responders in terms of drug treatment to different disorders is a huge issue because you always want to know, is this person going to respond, yes or no? And so perhaps based on GABA levels, we can start predicting whether our people are going to respond to GABAergic drugs or people aren't going to respond, which is substantially going to improve the treatment of these disorders. So we heard about vigabatrin a little bit, so this should be a question. So vigabatrin is an inhibitor of gamma aminotransferase. So if you give that to patients or to participants, what would you expect to happen? I'll try again. Right, we'll do hands. If you block GABA transaminase, who thinks that GABA goes down? Who thinks that nothing happens to GABA? Who thinks that GABA goes up? Right. Some people, that's the main response. All right, got 3 responses there. Okay, can we go back to the slides, please? All right. So here was a study where they gave vigabatrin to people with epilepsy. So vigabatrin blocks gamma aminotransaminase, which makes succinic acid from GABA and breaks it down. And so when you block the breakdown of GABA, you expect that GABA starts accumulating in the environment. And so that is exactly what they found. So they gave these patients different increasing doses of vigabatrin and found that up to 60 milligrams per day, the GABA levels went up in the brains in their brains compared to their baseline measure before vigabatrin treatment. In addition, what was very important clinically is that their numbers, the time since their last seizures went down substantially, and so there was much more time between seizures. And I think that is also an important thing to keep in mind, is that you can study the GABA system or give drugs, but ultimately what really matters is the outcome measures in these patients. Do they feel better, and do they respond to the drugs in a clinically relevant way? So in this case, a drug purposely led to increased GABA levels and accumulation of GABA levels by blocking the breakdown of GABA. But there's another very rare disease called succinic semialdehyde dehydrogenase deficiency. In this case, GABA is broken down to succinic semialdehyde, but doesn't get broken down to succinic acid. It kind of is blocked in that process because it doesn't get broken down any further. And so what happens is that you can start accumulating GABA in the environment. In addition, what happens is that through semialdehyde reductase, GABA starts broken down into GHB, which is more commonly known as a date-rape drug or as liquid E, which is really not something you want to have accumulating in your environment. And so these patients suffer from huge issues. So there's developmental delays, cognitive delays, seizures, etc. And so in this case, they did unedited spectroscopy, I would have to say, in the gray matter voxels in patients with this, in one single patient with this disorder. And they found that both GABA and GHB, which you can also measure using spectroscopy, accumulated substantially up to 300% in the voxels. And so here in this case, accumulation of GABA is a bad thing, and accumulation of GABA and too much GABA, as well as GHB, leads to neuronal damage as well as huge cognitive effects. All right, so based on all the talks so far, what do you think is the most important factor when studying, when looking at patient populations and seeing reduced GABA levels? This works. All right, who thinks motion is the biggest issue? Who thinks motion is the biggest issue? All right, who thinks medication is the biggest issue? Who thinks, you can go back to the slides, who thinks that gray matter composition is the biggest issue? One vote there. And who thinks that age matching is the biggest issue? Right, so I think that so all of the questions would have been right, but it depends on your population. So for me, working with pediatric populations, and particularly pediatric populations with who are hyperactive, often motion is for me definitely the biggest issue, because these children just move more. And we know that increased movement leads to reduced GABA levels. And so when I see reduced GABA levels, I need to make sure that there are no differences in data quality between these groups, or that there's not any outliers driven by poor data quality due to movement. Now, medication in other disorders is a huge issue, and the same for the disorders I study, because medication, as you have seen, can substantially affect the GABA levels in the brain. And so there are populations where, for scanning them, you might take them off medication. Now, sometimes these medications act acutely and they wash out very quickly, but there are medications where, even if they don't take it for 2 days, you still see a chronic effect. There's also populations, for instance, pain disorders, where you just can't get people off their medications because they suffer, and so medication needs to be taken into account when you're studying these different disorders. The same with as Dr. Harris talked about, tissue correction and tissue is a huge issue, but sometimes you are studying populations with a lot of atrophy, and so then you need to take into account that there is less gray and white matter in these voxels, and so you need to account for that. So age matching is actually something that you should be doing, because as we've seen, age can have a substantial effect on GABA levels, and if age is not the thing that you're interested in, you should age match and account for age in your analyses. So there's a couple of limitations I do want to talk about, and these limitations, and it's important to take in mind that some of these limitations that I just spoke about affect the actual GABA concentration in a neurochemical way, and some affect the GABA measurement that we have because they affect the quality of the measurement. So one thing that affects the quality of our measurement is scan quality and motion, and I think that is something that you need to look at. This is something you need to report, and this is something that you need to account for. And something that can substantially help with this is, for instance, training of subjects in the scanner, doing mock scans, taking them through with children. A story helps a lot. Sample size is a huge issue in clinical populations. I pointed this out before, but it is tricky because scanning clinical populations is difficult. Access to participants is difficult. So there's a lot of studies that do suffer from low subject numbers. So this is from the Schur paper, and you can see that a substantial number of studies have subject numbers within each group with less than 20 subjects. And so if your effect size is big enough, sure, you probably can see your differences there, but you might not be able to see differences when you have a heterogeneous but small sample size. You see this in an Iran paper, which was purely on autism research as well, that a lot of studies have fewer than 20 participants. Your study design is obviously very important, and I think this is something we've seen in the previous talks. There's a lot of different pulse sequences out there. You can scan at different field strengths, and I think that if you're comparing to other studies or if you're designing your study, keep in mind what pulse sequence you're using, what the benefits are, what the drawbacks are, whether you should be scanning at 7 Tesla or not. In addition, a lot of studies suffer from small voxel sizes and low SNR, and I think that is a big concern in spectroscopy literature in general, that they have low signal-to-noise ratios, and so the reliability and reproducibility of these measures is limited. There's a lot of variability in the region studied, and as we've seen, there are different results in different regions. The other thing is the nomenclature. I've seen studies where they use a voxel MPFC, and then you see the same study where they have the same screenshot, and they call it ACC. And so there's not very much consistency in what regions are studied and how they're named, and I think that is important. And the other thing that is a limitation of working with clinical populations is there's variability in the cohorts that you study, whether you have what inclusion and exclusion criteria you have, what comorbidities you might take and might not take, whether people are on medication, etc. The final thing I want to talk about is I would have loved to talk about other edited metabolites, particularly glutathione is an increased subject of interest. We can edit that very well. It is a marker of oxidative stress, which plays an important role in many disorders and can lead to damage of neurons, and so I think that is important. And particularly for looking at functional measurement, NAG as a neuromodulator might be a topic of interest as well. So, to summarize, GABA levels are altered depending upon the disorder. And they're related to psychiatric symptoms, behavior, and cognition, which is an important marker of function and could be a potential marker of treatment. This is probably more relevant than looking at differences in means between groups, but it is important to choose your outcome measures carefully in terms of that they're relevant to GABA and relevant to the disorder. Important to consider when you're interpreting your findings is where does the GABA difference come from? Is it in terms of synthesis or metabolism, neurotransmission, or is it just due to differences in tissue and interneural pathology? And finally, it is very important to think about your study design, your sample sizes, medication, heterogeneity, and comorbidities, as well as the acquisition that you're acquiring and the scan quality. They should be taken into account, and we're sometimes limited by the resources that we have, but these should also always be reported. So with that, thank you very much, and if there's any question, feel free to drop me an email, and I'll stick around as well. Thank you.